When we think about the human brain, we usually picture it as this ultimate impenetrable fortress.
Right. Yeah, like it's completely locked down.
Exactly, like, I don't know, Fort Knox. It has the thick bone of the skull, plus the tight molecular security of the blood-brain barrier, just keeping out all the toxins and, pathogens that circulate in our bloodstream every single day.
At a defense system, it really is an absolute marvel.
It is. But imagine what happens if a fire breaks out inside Fort Knox. And the security doors are locked so tight that the fire department just can't get in, and the smoke has literally nowhere to go.
Oh, wow. Yeah, that is a terrifying visual, but it perfectly captures the mechanical nightmare we are exploring today.
Yeah.
We are looking at a catastrophic failure of that exact security system where the body's own defenses basically turn against the brain.
Welcome to today's deep dive. We've got a massive stack of sources in front of us today. Everything from historical epidemiology papers to modern emergency medical texts.
It's a lot of heavy reading for this one.
Oh, for sure. And the mission you've given us is to map out one of the most terrifying failures of the human body. Meningitis. You have probably heard the word before, right?
Right.
It is on every emergency room's red flag list.
Absolutely.
But the true mechanics of how this disease inflames the brain's coverings and the intense medical debates surrounding how to actually treat it are completely wild.
Okay, let's unpack this. We need to define what part of the fortress is actually under attack here.
What's fascinating here is that to understand the disease, we first have to understand the anatomy. We aren't actually talking about the brain tissue itself.
Right.
We're talking about the meninges. This is a specialized three-layered membrane system that completely envelops your brain and your spinal cord.
Like a protective sleeve.
Exactly. You have a tough outer layer called the dura mater, then a middle layer, the arachnoid mater, and finally a delicate inner layer hugging the brain called the pia motor.
Okay.
And between that middle and inner layer is a space filled with a constant bath of cerebrospinal fluid, or, CSF.
Right. I always picture the meninges in that fluid, like the brain's custom-fitted bubble wrap.
That's a great way to think about it.
It's a biological shock absorber.
Oh.
So you jump, you run, and your fragile brain tissue doesn't just smash against the inside of your rough, bony skull.
And that bubble wrap is exactly where the trap is set. The textbook shorthand for meningitis is simply inflammation of the meninges. But medically, that simple definition hides a deep diagnostic fault line.
What do you mean?
Technically, the disease is defined by something called pleocytosis.
Pleocytosis.
Yeah, that is an abnormal spike in white blood cells in that cerebrospinal fluid, which doctors detect by drawing the fluid out.
Okay, so they're looking for the white blood cells.
Right. Notice the defining factor isn't the presence of a specific bacteria or a virus. It is defined by the immune system's response to those white blood cells flooding into the fluid.
Wait, I'm trying to wrap my head around the implications of that. You're telling me you can test someone, find absolutely no bacteria or pathogen in their spinal fluid culture, but they still technically have meningitis.
Yes. That is the paradox of aseptic meningitis.
Wow.
You have the inflammation, you have the excruciating symptoms, you meet the clinical criteria, but the culture is totally negative, and the trap swings both ways.
How so?
Well, a person can be infected with a known lethal meningitis-causing pathogen. The bug is actively swimming in their spinal fluid, but because their white blood cells haven't spiked yet, they don't officially show the clinical inflammation of meningitis.
So for you listening, imagine having all the signs of an agonizing infection, but the doctors can't find a bug. Or conversely, having a deadly bacteria hanging out in your spinal fluid, and your body hasn't even bothered to sound the alarm yet.
It's mind-bending.
It really is. And just to keep the terminology clear for the rest of our deep dive, meningitis is inflammation of those outer coverings and the fluid. Encephalitis is inflammation of the brain tissue itself.
Right.
And meningoencephalitis is when both are inflamed at the exact same time.
Which, sounds incredibly tidy on an anatomy chart. But in the reality of a chaotic emergency room, inflammation rarely respects those perfect borders.
Yeah, the body doesn't read the textbook.
Exactly. A severe fire in the coverings will very quickly singe the brain tissue underneath.
To understand why this specific fire is so dangerous, we have to look at the unique environment inside that skull. The brain operates under a concept biologists call immune privilege.
Yes, this is the core first principle of the disease. Immune privilege means the brain plays by entirely different rules than the rest of your body.
Right.
Because it is sealed off by the blood-brain barrier, it has almost no lymphatic drainage under normal conditions. and very limited immune surveillance.
So it's basically flying blind.
Essentially, yeah.
Yeah.
It doesn't have the same standing army of white blood cells constantly patrolling it that, say, your lungs or your gut might have.
And it does that to avoid collateral damage, right? I mean,
Yeah.
if you get a cut on your arm, your immune system rushes in, the arm gets red, it gets hot, and it swells up.
Right. Classic inflammation.
Yeah, and that's a normal immune response. It's fine because your skin stretches. The swelling has somewhere to go.
Yeah.
But the brain is trapped inside a fixed, rigid, bony vault.
The skull does not yield. The blood-brain barrier is superb at keeping things out to prevent that exact swelling scenario.
But if it fails,
If a pathogen manages to breach it, maybe it sneaks in through the bloodstream or through a direct physical route like a severe sinus infection, a skull fracture, or even traveling along peripheral nerves, the brain's scant immune response is caught totally off guard.
wow.
It has to activate almost from scratch.
And when it finally does activate, the resulting swelling becomes the killer. Because that compartment cannot expand, the rising intracranial pressure literally starts crushing the blood vessels against the bone.
Right.
It chokes off vital blood flow and oxygen to the brain tissue. It is the body's own defense mechanism acting as the executioner.
It really is. And before we move on, we should probably bust a major misconception here.
Oh, absolutely.
When people hear the word meningitis, the immediate association is a deadly bacterial infection. But the viral form is actually far more common,
And usually a lot less terrifying, right?
much less terrifying. For most patients with a healthy immune system, viral meningitis is typically self-limiting.
Okay, so it just runs its course.
Yeah, it resolves on its own without specific antiviral treatments. It is the bacterial form of the disease that carries the catastrophic mortality rates and those massive risks of permanent neurological damage.
I'm trying to put myself in the shoes of a doctor like 150 years ago.
Huh.
You have a patient dying from this invisible pressure cascade. You don't have CT scans.
No.
You don't have MRIs. The skull is literally a black box. How could early medicine possibly figure out what was happening inside a living patient?
Well, they couldn't. Not for a very long time. For centuries, meningitis wasn't even a recognized diagnosis.
Really?
Yeah, in the 19th century, doctors just relied on the vague catch-all term brain fever for any severe feverish neurological illness. The disease category had to be built in agonizingly slow layers.
Right, I saw that in the sources. In 1768, an Irish physician named Robert White described what we now know as tubercular meningitis in children.
Yes, but he had absolutely no concept that microscopic tuberculosis bacteria were the underlying cause.
Because the germ theory of disease wasn't widely accepted yet, people still thought sickness came from miasma or bad air.
Exactly. The paradigm shift was incredibly difficult to achieve. It wasn't until 1887, riding the wave of the germ theory revolution started by Pasteur and Koch, that an Austrian bacteriologist named Anton Weichselbaum finally broke through.
Okay, what did he do?
During a massive epidemic in Vienna, he isolated a specific bacterium from the spinal fluid of patients. He proved definitively that epidemic meningitis was caused by a tangible germ, what we now call Neisseria meningitis.
Wow.
It wasn't bad air, it was a microscopic invader.
But the tragedy of Weisselbaum's discovery is that he was still finding this out during autopsies, like after the patients had already died.
Yeah, that was the agonizing limitation of the era. The true methodological breakthrough came a few years later in 1891 from a German physician named Heinrich Quincke. He introduced the diagnostic lumbar puncture.
Literally sticking a needle into the spine.
Yes. And we have to appreciate the tension of this moment in medical history. To insert a needle into the lower spine, navigating between the vertebrae to draw out cerebrospinal fluid when the nervous system was still so poorly understood was an incredibly bold move.
I can't even imagine.
But by doing so, Quincke allowed doctors to safely sample the environment of the brain in a living patient.
Game changer.
Total game changer. It transformed meningitis from a disease you confirmed posthumously on an autopsy table into one you could actually diagnose, track, and potentially treat in real time.
That is just a staggering leap forward. But even before they could analyze that spinal fluid, doctors developed these incredibly specific physical exams right at the bedside.
Right.
The sources mention Budziewski's sign from 1909, where if the doctor flexes the patient's neck, the patient's hips and knees involuntarily pull up. Yes.
And Koenig's sign from 1882, where extending the knee while the hip is flexed causes intense pain and resistance. Reading about these, they sound like archaic parlor tricks. Why does bending a knee tell a doctor what's happening inside the skull?
I know, it seems completely disconnected until you look at the anatomy. The meninges don't just stop at the base of the brain, they extend all the way down the spinal cord, forming a protective sheath around the nerve roots that exit out to your legs and arms.
Oh, I see.
Yeah, so when those meninges are intensely inflamed by infection, stretching them is pure agony. When a doctor flexes the patient's neck, it pulls on the spinal cord.
Ouch.
The patient's body involuntarily yanks the hips and knees upward to create slack in those nerve roots. It is reflexive muscle guarding to avoid stretching the inflamed tissue.
The body is literally folding in on itself to relieve the tension on the spinal cord. That makes absolute sense when you visualize the anatomy.
But we also need to warn you about a dangerous misconception here. A lot of people think the absolute defining symptom of meningitis is a stiff neck. And if you or your child don't have a stiff neck, you're supposedly in the clear.
Oh, relying on that assumption is incredibly risky.
Yeah.
These classic signs, the stiff neck, Kernig's, Brudziaski's, they're notoriously insensitive in actual practice, meaning many confirmed cases don't show them at all.
Wow, really?
Yes. This is especially true for infants, the elderly, or anyone who is immunocompromised. An infant with bacterial meningitis might not have a stiff neck. Instead, they might just have a bulging soft spot on their head, the fontanelle, due to the pressure.
That's terrifying.
Or they might just be alarmingly lethargic or refusing to feed. Waiting for a stiff neck will cause you to miss cases, which is why clinical suspicion and prompt lumbar punctures are prioritized over everything else.
Because that rigid bony box turns inflammation into a fatal pressure cooker so quickly, the moment those bedside signs show up, the clock starts ticking. It forces doctors to make incredibly aggressive split-second decisions. And looking at the history of these treatments, it is a high-stakes world.
It really is. Before targeted treatments, the mortality rate for bacterial meningitis was brutal, around 70 to 80%.
That is just bleak.
The first major dent in those numbers came in 1913 when Simon Flexner at the Rockefeller Institute developed an anti-meningococcal serum therapy. That dropped mortality to about 30%. Then came sulfonamides in the 1930s and penicillin in the 40s.
But even with a pharmacy full of modern antibiotics, things can go wrong terrifyingly fast. The medical text outlined this nightmare scenario called Waterhouse-Friderichsen syndrome.
Yes, that is the one you dread.
Basically, in severe meningococcal infections, the bacteria replicate so aggressively in the bloodstream that patients suffer catastrophic bilateral adrenal hemorrhage. Their adrenal glands fail, their blood vessels leak, and their circulatory system collapses. A perfectly healthy child can show mild symptoms in the morning and be in fatal septic shock by the evening.
It is one of the absolute can't-miss emergencies in all of medicine, and that specific syndrome often presents with a very terrifying visual clue on the patient's body, a purplish skin rash of petechiae and purpura.
Wait, petechiae and purpura, for those of us without medical degrees, we're talking about those tiny pinprick blood spots that pool under the skin, right?
Correct. They look like tiny bruises or purple dots, and they indicate that the blood vessels are literally bursting beneath the skin due to the overwhelming infection.
Which brings us to the glass test. If you're listening to this and you have young kids or you just want to be prepared, this is a brilliantly practical tool taught in emergency medicine worldwide.
It's so simple, but so effective.
Yeah. If a rash appears, you take a clear drinking glass and press the side of it firmly against the skin. A normal viral rash will blanch. It'll briefly turn white or fade under the pressure of the glass.
Right.
But this meningococcal rash does not fade. It stays violently purple right through the glass because the blood is already outside the vessels, trapped under the skin. It is a massive red flag to get to an ER immediately.
It is a vital tool for parents and doctors alike. But once the patient is in the emergency room, the medical team faces incredibly difficult decisions. For decades, there was a fierce debate about whether to mandate a CT scan of the brain before performing that crucial lumbar puncture.
Right, because the fear was that if the pressure inside the skull was dangerously high, puncturing the spine below it would create a vacuum effect. The brain tissue would physically herniate, just get sucked downward through the base of the skull, which is instantly fatal.
Exactly. So the logical response was to establish a rule. CT scan first, just in case.
Makes sense.
But the fatal flaw in that logic was time. Getting a patient to a CT scanner takes time. Waiting for the radiologist to read the scan takes time.
And time is brain.
Exactly. All that waiting meant delaying the administration of life-saving antibiotics. The clinical evidence eventually caught up and showed that this excess caution over a rare risk like herniation was actually creating a much more common and severe risk treatment delay.
So what's the protocol now?
The medical standard today is clear. Empiric antibiotics should be given immediately. You do not delay life-saving treatment for a scan.
Here's where it gets really interesting, though, the medication paradox.
Oh, this is a big one.
You give the antibiotics to kill the bacteria, which sounds like the goal. But when those antibiotics blow the bacteria apart, the fragmented cell walls act like microscopic shrapnel in the cerebrospinal fluid.
Yeah.
They trigger a secondary explosive immune response, which violently worsens the swelling in the brain.
It is a devastating catch-22. To counter that secondary explosion, researchers sparked a decades-long debate over giving dexamethasone, a powerful steroid, alongside the antibiotics to blunt the inflammatory response.
But the steroid isn't a universal silver bullet, right?
Not at all. In fact, it remains a live area of clinical debate. Trials in the 1990s and early 2000s in high-income settings showed that giving steroids successfully reduced hearing loss in kids with Haemophilus influenza meningitis and lowered mortality for adults with pneumococcal meningitis.
Sounds great.
But when researchers tried to replicate those exact same protocols in major studies in Malawi and Vietnam, the steroids completely failed to show a mortality benefit.
Wait, why the discrepancy? If the biological mechanics of the brain are the same everywhere, why would the drug fail?
Because the medical context dictates the outcome. In those lower resource regions, patients often presented to the hospital much later in the course of the disease when the damage was already done.
That makes sense.
Furthermore, the mix of bacterial pathogens driving the infections was entirely different. The risk-benefit balance shifted. It highlights how a pristine treatment protocol from one hospital doesn't universally translate without factoring in local epidemiology and healthcare access.
Just to add one more layer of chaos for the doctors, you don't even need an infection to get that dangerous swelling. The sources highlight drug-induced aseptic meningitis.
Yeah, this is a tricky one.
Routine medications, like NSAIDs, think everyday ibuprofen, or certain antibiotics, can occasionally trigger the exact same spinal fluid inflammation. This is exceptionally tricky for patients with underlying lupus. An ibuprofen-triggered meningitis looks identical to a lupus flare or a real infection, leading to massive, completely unnecessary courses of antibiotics.
If we connect this to the bigger picture, all of these diagnostic traps and treatment delays illustrate a vital truth. The ultimate medical victory over bacterial meningitis isn't about better treatments in the ER.
No.
It is about changing the landscape entirely so the pathogen never breaches the fortress in the first place.
Prevention over reaction. Which brings us to the vaccines.
Vaccines have literally rewritten the global epidemiology of this disease. Look at the meningitis belt, a defined geographic band stretching across sub-Saharan Africa, from Senegal to Ethiopia.
For decades, that region was absolutely hammered by one specific type of the bacteria, serogroup A meningococcal disease.
Yes. Many people naturally carry an Neisseria meningitidis harmlessly in the back of their throat. But in this specific belt, the dry season winds and environmental factors triggered massive recurring epidemics with attack rates seen nowhere else on Earth.
Wow.
Tens of thousands of people would be infected in a single season. Then, in 2010, public health organizations rolled out a mass vaccination campaign with a specialized conjugate vaccine called Mina-Afrivac.
The numbers from that rollout are almost hard to believe.
The impact was unprecedented. Within a few years, epidemic serogroup A disease was nearly eliminated in the vaccinated countries.
That's incredible.
And what's crucial to understand is how this works. It wasn't just protecting the individuals who got the shot. The vaccine actually stopped the bacteria from colonizing in people's throats.
Oh, wow.
Yeah. By interrupting that carriage, the bacteria literally had nowhere to go, suppressing transmission across the entire community. It is one of the cleanest modern demonstrations of herd immunity protecting the unvaccinated.
We saw a similar epidemiological transformation in the United States with pediatric meningitis. Before the late 1980s, Haemophilus influenza type B, or Hib, was the leading cause of bacterial meningitis in American children. It infected thousands every year.
It was devastating.
And the sources are very clear that even for the kids who survived, the long-term sequelae were awful, especially severe sensorineural hearing loss.
Survival in meningitis does not equate to full recovery. The intense inflammation damages the delicate cranial nerves, leaving many survivors with permanent cognitive impairment, seizure disorders, or profound deafness.
Which is just heartbreaking.
It is. That is why post-recovery audiology screening is now an absolute standard of care for children who survived the infection.
Well, once the routine infant Hib vaccine was introduced, cases plummeted by over 90% within a decade. Researchers note that pediatric meningitis in the U.S. today is practically a completely different disease than it was 2 generations ago, dominated by entirely different pathogens.
An undeniable public health triumph. However, this leads to a final vital misconception we need to clear up based on the sources. People often assume meningitis is something you just catch in passing, like a common cold on the subway.
Right. Someone sneezes in your general direction and suddenly your brain swells.
Exactly the fear, but largely untrue. While meningococcal meningitis is spread via respiratory droplets and close, prolonged contact, which is why military barracks and college dormitories are high-risk zones that mandate vaccines, most forms of meningitis are not highly contagious in casual, everyday settings.
That's a huge relief.
And many causes, like fungal meningitis or the drug-induced cases we just discussed, aren't contagious from person to person at all.
So what does this all mean? We've traced an incredible physiological journey today. We started with the brain's immune privilege status, which acts as a brilliant fortress until a pathogen manages to break in.
Right.
We look at the rigid box physics that turns our own inflammatory defense mechanism into a lethal weapon. We saw how Heinrich Quinchy's daring lumbar puncture finally illuminated the black box of diagnosis,
Such a huge milestone.
and how vaccines have totally reshaped who gets sick and why.
Understanding meningitis is essentially a masterclass in human physiology. It demonstrates how the body's greatest defense mechanisms, the tightly sealed blood-brain barrier, the rigid armor of the skull, can rapidly become its greatest vulnerabilities.
Yeah.
And practically speaking, it highlights the life-saving value of simply knowing what to look for, like using that glass test for a non-blanching rash. It remains a critical, can't-miss emergency where time dictates everything.
It really is a race against the clock. And I want to leave you with a final thought to ponder that spirals out of everything we just explored. We established that the brain's tightly sealed, immune-privileged environment is exactly what makes a bacterial breach so uniquely devastating.
Yep.
The rigid confines of the skull turn inflammation into a fatal pressure cooker. But right now, modern medicine is pouring billions of dollars into figuring out how to intentionally breach that very same blood-brain barrier to deliver life-saving drugs for complex diseases like Alzheimer's or brain cancer.
Right.
So if keeping things out is this dangerous when the system naturally fails, what on earth happens to that delicate balance when we intentionally try to break in? Food for thought. Thanks for joining us on this deep dive. See you next time.